Hi everyone, this is Dr. Chalam, the host of Women Wired for Wellness. Today's podcast, I'm going to be discussing something that was posed to me as a specific question. What is gluten sensitivity? What is the science behind gluten sensitivity? Does it even exist? And how do you find more information about this? So let's delve a little deeper into gluten sensitivity because I think this is a very important topic. Everybody follows what they see on the internet, what they watch on the internet. And there's a saying, right? Be careful when you follow the masses. Sometimes the M is silent. So I'm going to try and get in this podcast some information for you to make that determination whether you need to be free of gluten for the rest of your life. I'm Dr. Chalam, founder of Holistic and Integrative Center of Novi, the best place for you to find your best doctor, and that will always be you. Okay, gluten sensitivity, is it a fact, fad, or a fashion? And this is presented to you by Holistic Icon. So those of you, once again, listening to it on the podcast, hop over to YouTube to look at the slides. Otherwise, just listen to me and I'll explain each of the slides in detail. So before we get into gluten sensitivity, I want to talk to you about two important things. One about gluten and the other about how digestion takes place. So the most important aspect about eating is actually how you chew the food. Believe it or not, there has been a study about it. And chewing food is probably the single most important act in the process of digestion. So your digestion begins with you thinking about food. For instance, just close your eyes and think about the sour lime drops on your tongue. You will actually salivate. And that's something that happens to us when we think about food. Our most favorite food, your mouth begins to water. So, really, digestion begins in your brain. The watering of the mouth is getting your body ready for digestion. So, chewing the food, that's why we have teeth. Otherwise, we would be born without teeth like babies, and just all we did was to drink smoothies and drink soups all day long. But we have teeth because the chewing process is very important for beginning the digestion of food. What has this got to do with gluten sensitivity? Just be patient with me and I'll explain it to you. So, one of the bigger challenges of the industrialized and the modern life we lead is there is no focus on the food we eat. Food becomes an afterthought. It becomes something we get to do because it's time to eat. We have no connection with our hunger. So what we get to do is we just get food as we're working on our jobs, or we're like walking around doing household work and snacking constantly, right? There is no focus on how the food is prepared, how the food is being eaten. But we also think of it as a task that just has to be done and be like moved out of the way. Some people are so busy that they forget to eat. Now, I wish I was one of those, but I'm not. But some people do. And then when they finally get home, they're so famished, they eat everything in sight. And there are others who just skip meals and they really become undernourished and they become irritable and cranky people. So we really want to focus on not only spending time with your food, chewing the food, and don't use it as an entertainment all the time. It's okay to have occasional entertainment, like once a week, you're having a good, happy meal outside. I don't mean literally a fast food, but food that gives you pleasure more than it being just nourishing. Chewing is to establish digestion. And like I said, they've studied this. You need 40 chews. Most of us do at the most 5 to 6 chews of each mouthful of food. Some people just do 2. The less chews, the worse the digestion, the more weight you gain. And actually, this has been shown. Chewing the food and actually making it liquid before you swallow helps you get full faster, helps the food digest really well. So, This figure that I've shown you here, this is actually a piece of bread. So I'm showing, for those of you listening to the podcast, there's a cartoon of somebody eating a bread. I've got the stomach and the intestines, and I've highlighted the duodenum, which is the area where we're going to get affected if you have a problem with gluten. So a few things that I want you to understand about this particular slide. Food intake increases salivation, and the enzyme amylase. Amylase actually breaks down all of your carbohydrates. It's actually the teeth break down the food mechanically, biochemically is the enzymes in the saliva. It breaks it down and it increases as the food hits the mouth. There's already a lot of communication going on in your body, and the gastric juices increase, getting ready for the food to come into the stomach. And remember, acid kills the microorganisms, breaks down the food. At the same time, there's another little hormone that gets produced called the incretin. Incretin is something that's produced in the intestines, and an example is GLP-1. It's glucagon-like peptide 1. This is very important, particularly if you have problems with blood sugar. Now, why am I talking to you about this for gluten sensitivity? You'll get to know it. So just follow me along. So when you get food, your amylase in the mouth increases, gastric juices increases, bile gets ready to be poured into your jejunum, or the small intestine, beginning of the small intestine. Pancreatic enzymes to break down protein is getting ready to be produced, but there's also another little enzyme that comes from your small intestine called GLP-1, glucagon-like peptide. What is the role of glucagon-like peptide? Is to help with your blood glucose control. In other words, GLP-1 increases the function of insulin, increases the cells that produce insulin, that is called the beta cells, live a little longer. So GLP-1 is a very important hormone that's produced by the small intestine in response to food. Now, GLP is destroyed quickly by another enzyme called DPP4. It's dipeptidyl peptidase 4, and just again, make a note of this, park it in your brain, because I'm going to come back to this, and this is going to be very important. So GLP-1 that helps with your blood sugar control. If you're a diabetic, this is very important for you to understand. What is a GLP-1 like medicine? It's something like Byetta or Trulicity, something that increases the GLP-1. DPP4, an example of a drug that actually destroys this particular enzyme so that it doesn't shorten the life of GLP-1, is Januvia. So we want everything within our power to increase GLP-1 so your blood sugar control is better. That's all you need to remember. And DPP4 destroys GLP-1. So the shorter the life of DPP4, the better our blood sugar control. What has this got to do with gluten? Follow along with me, and I'm going to explain that to you. So GLP-1 is an incretin, and it's destroyed by DPP4. Park this previous slide. I'm going to go back to it. Park this previous slide in your brain, because we're going to get back to it. So now I've explained a little about digestion. We're going to go to the next topic as to what is gluten. Gluten, the GLU, is basically GLUE. It's the glue that holds things together. It's actually a protein which is found in carbohydrates. And when you really look at it, it acts as a glue. It helps the rising of the bread when you add the yeast and the baking soda or baking powder, whatever that is that you add to bring the rising of the bread. And it helps the flour stay together. So those of you who have been gluten-free, you know the difference between a gluten bread and a gluten-free bread. Gluten-free bread just falls apart because there's nothing holding it together. So once again, gluten is a protein found in carbohydrates. Why is this important? When you look at 65% of the carbohydrates consumed worldwide, it comes from a few of these things. It comes from wheat, it comes from barley, it comes from oats, and it comes from maize. Now, these are gluten-rich carbohydrates. Even if you look at the whole grains, they're gluten-rich carbohydrates. And we'll get back to how do we know about this? What is the history behind this? So when you look at the evolution of food, we started off, it looked like human beings were nomads. They walked around, there was a lot of vegetation, they ate plants mostly. But at some point, the earth actually changed, the climate changed. Probably climate change was there way before industrialization. So when the climate changed, the vegetation actually died out and it became a desert. And really, at that point, for human beings to survive, they started eating carcasses of dead animals. So they started, I'm not really sure if they cooked the meat, but that's how they began from gathering to hunting. So now, if we were continued, say that no industrialization took place, no scientific advances took place, we probably would die of starvation. And that's how human beings died. We died of infection or starvation, or because another animal killed us. As we got older, we were a part of tribes or nomads in a group. There was a lot of hunting and gathering. Now, over a period of time, man began to from moving from gathering to hunting, and I know I went past that slide, but moved from gathering to hunting, also moved to cultivation. Now we started cultivating our food. That is how a lot of the carbohydrates came to being, mostly the whole grains. These are cultivated plants. In fact, today, I don't think we have any natural plants, right? Most of our vegetables are cultivated. That's why we have those perfect, beautiful, uniform sized carrots. They're all beautifully orange, or all our bell peppers look the same, all our bananas look the same, because everything is cultivated and pretty much orchestrated food we get to eat. Talk about why we're ill today. Same thing with the animal meat. We're no longer hunting wild animals, we're cultivating. We have agriculture basically getting the same kind of breeding, the same kind of animals. In fact, there's also some data that shows there's a specific bull sperm is used to actually impregnate the cows, and we have similar cows and similar beef. And therefore, there's a lot of our food is pretty much orchestrated. So way back when the Egyptians and the Greeks started cultivating, one of these doctors, one of the Greek doctors, found that some of his patients were actually dying of chronic diarrhea, bloody stools, abdominal bloating. So he knew it was abdominal pain, there was bloody stools, weight loss, malnutrition. They were not getting the nutrients, and then eventually died. And he called it, when you really look at the history, it's called celiacos, or the abdomen, pointing towards the abdomen in the Greek times. Then it became the celiac affection, I think in somewhere in the 1800s, and now it's called the celiac disease. So this is where gluten is most known as a part. In fact, it is defined as celiac disease when you have an intolerance to gluten. That's how in traditional medicine we look at gluten sensitivity, is when you have celiac disease. Now, over a period of time, we have figured that it's not everybody presents themselves as celiac disease. So what is celiac disease? It's an intolerance to gluten. Like I told you, 65% of the carbohydrates have gluten. Gluten is 95% of the protein in these carbohydrates. The remaining 5% has albumin, globulin, and trypsin and other proteins. Now, what they found is not everybody presents themselves as celiac or gluten not even in sensitivity, it's actually gluten intolerance, and that is celiac disease. There are two other main conditions. So let's talk about the three identified gluten-related disorders, or GRD. Number one is celiac disease. Number two is wheat allergy, and number 3 is non-celiac gluten sensitivity. And I'm going to delve into each of this in a little more great detail so you can understand number 3, which is non-celiac gluten sensitivity, which is why most folks, particularly when they are a part of a functional medical practice or a holistic or integrative practice, they tend to present with non-celiac gluten sensitivity, or so we think. So gluten has 2 major proteins, gliadin and glutenin. And then it has these other proteins, like I told you, 5% of other proteins, which are albumin, trypsin, and globulins. Now, gliadin and glutenin are so difficult to digest. You need very robust enzymes to break them down. Once again, remember that particular slide I told you about digestion, the amylase, the gastric juices, the glucagon-like peptide 1 and DPP4. We're going to go back to this when we're talking about digestion of gluten. So let's take the very first one in terms of digestion is number 1 point that you have to remember about gluten is it's very difficult to break down gluten. Number 2, you need very robust proteolytic enzymes. I find that in my practice, by the time people come in their 50s, they have very poor digestive capacity. That's why they tend to feel bloated, particularly with certain foods. So how do we damage our pancreas and the bile and everything else? It's because of the foods we eat. If for a very long time you've been eating processed food, and you may say, I don't eat processed food, I eat healthy. And then the first thing I ask people, like, oh, okay, you eat healthy. Tell me what you have for breakfast. And they'll say the Ezekiel, something that starts with an EZ, that bread. Well, what is that? That's whole wheat bread, and it's not necessarily healthy. Everybody thinks it's healthy, and they say it's healthy, so they eat it. It's filled with gluten. And it's very important to understand you need a very robust digestive system to break that bread. Number 1. Number 2, it is processed. Somebody else made it for you. You didn't make it yourself. So that is a highly processed. You're buying it ready-made. All you need to do is toast it and eat it, right? So that's important to remember. So processed foods, doesn't matter what the label says, is something that was manufactured in a factory and wrapped for you, packaged for you with a label, and you just open and eat. So you're eating processed food. You need a robust digestive system to break it down. The digestive system, particularly the small intestine, has these hair-like projections. Now, a lot of the mucosal linings, the linings of the inner sides, all the pipes, so that's our respiratory system as well as our digestive system, have these hair-like particles. They're called cilia in the lung and villi in the intestines. They have a specific, I would say, job. In the lung, it removes all the dust particles and gets bad bacteria out. It's very important. That's why smokers tend to have more bronchitis, because they destroy their cilia. And similarly, the villi in the small intestine can get damaged by gluten. It can get damaged by gluten. It can get damaged by infections. And sometimes people have a bout of diarrhea, and after that, they cannot digest gluten after following an episode like that. So the villi can be destroyed by an immune reaction, by an infection, and we just have to figure out which. When the villi get damaged, these little hair-like particles on the intestines, of which I will show you a picture in a moment, you don't have good absorption. There's poor absorption of nutrients, poor movement of the food, or quick movement of the food. So what I want you to understand is in celiac disease, it's an autoimmune condition. What is an autoimmune? That means self-destruction by the immune system. Where does the self-destruction happen? It happens in the small intestine. And because that's where your gluten is getting absorbed, broken down and absorbed. The population, the presence, how prevalent is celiac disease is 0.5 to 1.7% of the population struggles with celiac disease. Now, it's also very important to understand celiac disease was identified in the gastrointestinal tract, but celiac disease can present itself in other ways, according to a lot of the people who do research on gluten, which is why we have this third entity, non-celiac gluten sensitivity. Most people with celiac disease, almost 95% of them have the HLA-DQ2 and HLA-DQ8. It's a genetic trait that puts them at a higher risk for developing celiac disease. They also have on blood tests immunoglobulins A and immunoglobulins G against the two proteins. Remember, I told you the gliadin, glutenin, sometimes against the muscle cells. So you can get gliadin and transglutaminase antibodies when you do the testing. On biopsy findings, this is how we diagnose celiac disease. We take a small piece of the duodenum and check the cells. Remember, I told you about the villi? Those villi are completely destroyed in celiac disease. Instead of a shag carpet, you have berber. And there's a lot of inflammation. And this inflammation is identified by surgeons as the Marsh criteria. They have 1 to 4, 4 being the highest, lots and lots of inflammation and destruction. And most people with celiac disease have 3 and 4. Quite significant inflammation, but particularly destruction of the villi. So the surgeon, when they do the biopsy, they're specifically looking for this destruction of this villi in celiac disease, because that's what puts you at a high risk for lack of absorption of your nutrients and all of the symptoms of celiac disease. So this is the picture of what you see in a celiac patient. And those of you listening just to the podcast, I have a picture of a intestine, a cartoon-like picture of the intestine, and little poop with blood. That means bloody diarrhea is seen with people having celiac disease. So another picture here, this is where you have the blood vessels coming to the top of the villi, those hair-like projections that you see, they are the cilia. That is what is interacting with the contents of your small intestine. So food and bacteria come here, and the villi actually absorb, get it to your blood. Now, this villi is extremely important for good absorption. Now, what happens is with the celiacs or people with celiac disease, this villi, like I told you, the shag carpet becomes berber. The whole thing gets destroyed. You're no longer, can you see that? Those projections are gone. Now you can no longer absorb a lot of nutrients. So you'll find celiac disease, they have anemia, chronic anemia, they have chronic malnutrition, they have this bloating sensation, they have this vague abdominal pain, on and off diarrhea before they get diagnosed, particularly because a lot of women tend to suffer from this, and even children. It takes a long time for them to get diagnosed unless they are having the classic signs and symptoms of bloody diarrhea. And then again, the surgeon has to find on biopsy findings this loss of villi. But once the celiac disease is diagnosed, it's easy. You just have to avoid gluten, or so we think. So let's talk about the next one. So celiac disease is very clear. Number one, you have a genetic trait. Number two, you have a pathology, which is destruction of the cilia. Number three, you do have blood tests that are positive. Now, wheat allergy, what are the criteria for wheat allergy? That means these are people not just sensitive to the gluten, but they're sensitive to the other proteins or other things in the wheat, including probably the sugars, not just the protein, but actually the carbohydrate in the carbohydrate. So wheat allergy, there's no genetics. There's no HLA, no genetic trait. This is wheat allergies like any other allergy, like a peanut allergy, like an allergy to dust and mites. It's a blood work for immunoglobulin E. Remember, the other one was immunoglobulin A and G for celiac disease. This is immunoglobulin E, just like any other allergies. You get hives when you are exposed to certain chemicals. That's an IgE reaction. So biopsy may show some inflammation. Remember, I told you 4 stages of inflammation, 1, 2, 3, 4 Marsh stages, but there is no loss of villi. So people are not actually not absorbing it. By the way, there's a spelling mistake. I noticed that. It's villi, but villi. So wheat allergy, no genetics, blood test is positive for IgE, biopsy does not show loss of villi, maybe showing some inflammation. 9% of the population has this. So much higher population has wheat allergy as opposed to celiac disease. So you get the picture how the two things are different. One has a genetic trait, second one doesn't have a genetic trait. Both of them blood tests positive, but one has a different type of immunoglobulin. This has IgE, very classic allergy. One has destruction of villi, the other one does not have destruction of villi, and it's IgE or wheat allergy is more prevalent than gluten, um, or I should not say gluten sensitivity, actually celiac disease, right? Very classic. Now, the third one was non-celiac gluten sensitivity, or NCGS. What is NCGS? Pretty much no genetics, right? No genetics, maybe 50% chance of having one of the HLA DQ traits. So that's like a flip of a coin. It may or may not be there. Number two, no specific blood tests. There's no specific blood test that tells me that, oh, you have non-celiac gluten sensitivity. 50% have what is called the native anti-gliadin antibody. Once again, this is not very, like if you just took 100 people, 50 of them would have anti-gliadin antibody, but they would all not respond to gluten the same way. So again, it's not causative. It's not something that you don't see it always in association is what it means. So 50% chance that you could have any of this. Biopsy may show inflammation, but there's no loss of villi. So this is where non-celiac gluten sensitivity becomes difficult. No genetic trait, no specific blood tests, no destruction of villi. So it's almost like it doesn't exist, right? And no population-based studies, so we don't know how many people have this. We can't even say that because we don't have specific diagnostic criteria. So no genetic trait, no specific blood test, no destruction of villi, no population studies. In traditional medicine, this doesn't exist, but in functional and integrative medicine, this does exist, which is one of the reasons we delve a little deeper into this. So what is non-celiac gluten sensitivity? This is otherwise called self-reported gluten sensitivity. So people come and tell their physician, you know what, if I eat gluten, I feel bloated. Now, if you go to a regular doctor, they'll say, no, gluten is very important. And don't dismiss that, because I'm going to give you the science behind why they say that. But most of the non-celiac gluten sensitivity is discovered due to self-reporting. So people feel bloated. They have so much of discomfort. It's almost like they have an irritable bowel, sometimes constipation, sometimes diarrhea. But every time they note it is due to gluten-rich foods. So irritable bowel is not to any specific food, but you have similar bloating, discomfort, and it's so much there's a lot of similarities between the two. Sometimes even inflammatory bowel disorders can be mistaken, or gluten sensitivity can be mistaken for inflammatory bowel disorders, just how they present. There are other associated symptoms. So this is not just with your gut. What do these people feel? They have sometimes other autoimmune conditions, particularly skin conditions, psoriasis, eczema, and they may have dermatitis. They could have brain issues like mood disorders, particularly depression. Schizoaffective and autism has also been affected by the presence of gluten-rich foods, and then brain fog. They can have autoimmune conditions like rheumatoid arthritis, lupus, and Sjogren's. So self-reported gluten sensitivity is what we consider as non-celiac gluten sensitivity. So there were a lot of studies, they've been trying to understand this non-celiac gluten sensitivity, because remember, what did I tell you? No genetic trait, no specific blood test, no destruction of the small intestine, and no population study. So does this thing exist? Is this a fad or a fashion or a fiction? Because a lot of celebrities really say they're gluten-free. They talk about gluten sensitivity, talk about abdominal symptoms, but we don't have too much to back it up. So they've done a lot of studies. Now, these studies are very difficult to do. But there was one, I mean, among the several studies, one study that really, when I went through all of the studies, just stood out is there's two groups of people that they took, and they gave gluten-rich food to one group and gluten-free food to another group. So group A and group B. Group A got gluten-rich food, and the other one got gluten-free food. So after about a few weeks, they did a washout. That means they didn't, give them any of those. They just did 2 weeks, and then they switched the groups. They said the people who ate gluten-rich food now will get gluten-free food, and those who were gluten-free will get gluten-rich food. Now, what was interesting is that the groups themselves, A and B, did not know what they received either of the times. They didn't know if they got gluten-free or they got gluten-rich. Now, if I were somebody who ate gluten, I could immediately tell the difference between gluten-rich and gluten-free. But anyways, this is how they did the study. And they found, this is very important, they found only 30% could effectively identify a gluten-rich diet. That means they said, I was affected by this food that was gluten-rich, and they found that they were accurate, only 30. So 70% could not identify it. But here's the problem with this study. What they found is people react to the non-gluten part of the food. What is the non-gluten part of the food? Remember, there are other proteins in this carbohydrate. Not only 95% is gluten, but there are other proteins like albumin, globulin, and trypsin. And there are also other carbohydrates in these carbohydrates that are called FODMAPs. Many of you who have struggled with abdominal issues understand FODMAPs. FODMAPs are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, they're basically short sugars, just under 10 carbon atoms, small sugars, easily digestible, easily fermentable by the bacteria of the gut. So people could actually be reacting to the carbohydrates in the carbohydrates rather than the protein in the carbohydrates. You get where I'm going? So what do these people actually react to? Is it actually to the gluten, or are they reacting to the carbohydrates? In fact, some people who come to us with very advanced stomach issues, if they go on the low FODMAP diet, which is a temporary diet. I have to emphasize this. For those of you who do your own Google training, Google University training, Google University MDing, right? Basically, you're doing your own medical treatment. FODMAPs is a therapeutic diet. It is not something that you do for the rest of your life. If you cannot go back to regular eating, that is a problem, because FODMAPs, as it says, fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, are extremely important to the health of your gut and the bacteria in your gut. Remember, we are more bugs than cells. And it's important to have the right kind of bugs, and these fermentable, the FODMAPs, actually create the right kind of bugs in our gut. So it's extremely important to understand when you react to a gluten-containing food, it is important to identify, are you reacting to the gluten? Are you reacting to some of the protein in that carbohydrate, or are you reacting to the sugars, the short sugars in the carbohydrate? So again, very important to identify, establish this for gut health and microbiome, which is why testing becomes very important. So now let's talk about, how do you identify if somebody has non-celiac gluten sensitivity? Because it is a fact. People are reacting to gluten. It is not a fad. However, what I want to establish in this podcast is for you to scientifically think through this process and understand, do you need to be gluten-free for the rest of your life? So there is a group of folks who study gluten. They came together in Italy, and they created this, what is called the Salerno's protocol, or Salerno's expert guidance on how to identify non-celiac gluten sensitivity. So the way you do that, and which is how we do our detox protocols in our practice, and I think most functional medical practices will do this, you take somebody completely off of gluten for 6 weeks. In fact, when gluten sensitivity was identified centuries ago, they found that those people survived off of rice. The minute they ate the cultivated wheat, they would have the bloating and bloody stools and all of those things. But so we give you actually gluten-free foods, a list of gluten-free foods, get you off of gluten for 6 weeks complete. Then you, because that becomes the most important part, getting the right kind of gluten-free diet. And you want to note the improvement in your symptoms. So when you come to a practice like ours and you say, you know, I have bloating sensation, I don't feel so good, my stomach feels horrible, we get you on a gluten-free diet. And also, I have to mention at this point, when you are gluten sensitive, you most likely are sensitive to casein, milk products. So we take people off of dairy and gluten together, and there will be some improvement of the symptoms if this is due to gluten. So you'll have less bloating sensation, your bowel movements will change, your regularity will get better, you'll find the consistency of the bowels will change. So you start making note of those improvements. Usually the improvements begin within about the second week and continue on and become really almost normal by the end of 6 weeks. Then you reintroduce gluten, and the way the experts recommend is the gluten has to be evenly spread in the food item. So like a muffin or a bread piece, which has, I think, almost like 16 grams of gluten. And you watch for recurrence of the symptoms. Now, in our program, we actually detox, which is detoxes like rebuild the gut health with some supplements and the right kind of diet, and then reintroduce food that is rich in gluten. But either way, we're trying to look for any bloating sensation, fatigue, the mood swings, or skin rash, any of those that might return. Once we do that, we're able to establish, okay, this person has some degree of gluten sensitivity. So a little about the FODMAPs, very important for, this is the glucose in the carbohydrates, or the sugars, carbohydrates in the carbohydrates, I should say, the short sugars, very important for lactobacillus, and many of you who buy probiotics, mostly lactobacillus. And it is, why do you have a reaction to FODMAPs? Usually an imbalance of the bacteria. But I would also say this, if you are sensitive to gluten or milk, it's because maybe there's a genetic trait for you not to digest lactose. A lot of adults, a good percentage of the adults do not digest lactose once they've come into adulthood. But at the same time, there could be an imbalance of the gut bacteria. And remember, by the time you reach your late third decade, the fourth decade, or fifth decade, a lot of inflammation in the gut due to either poor eating habits, chronic stress, or exposure to chemicals. There could be any number of things, or antibiotics could have destroyed the lining of the gut and altered the gut bacteria, and that can set you up for food sensitivities. So that's why I don't like to do food sensitivities, because food sensitivities does not mean you're sensitive to the food. It means you have a problem with your gut and your gut needs fixing. I want you to hear that again. Please listen to me when I say this particular thing. Food sensitivity means there's a gut issue. People tend to get malnourished doing food sensitivity testing and avoiding everything that shows up on their food sensitivity. Food sensitivity can happen from a few things. Antibiotics, overuse of antibiotics, exposure to chemicals, destruction of the gut lining just from chronic stress. Sometimes it can be because you've been eating not necessarily healthy. So you cannot be on low FODMAPs for a long time, for the rest of your life. And a lot of people tend to do this very often. They get on a low FODMAP diet because they see it on, on Google University, for lack of a better term, on their internet search, because they cannot find an answer to their bloating sensation. But low FODMAPs, they would get on a low FODMAP and they'll continue to stay on it. And that eliminates a lot of your fruits, vegetables. And that's not very good for you, because fiber, if there's anything that you want to do to shift your health, overall health, is addition of fiber, digestible fiber, feeding the bacteria of the gut, and resistant fiber. Both of those have to be added to your diet. Going on a low FODMAP eliminates both of those, therefore eliminates the possibility of the good bacteria to grow. So what about going on a gluten-free diet? Should you be doing that once you've been diagnosed with a non-celiac gluten sensitivity? That is another important question I want to answer. So just to summarize so far what we have come up with, you have celiac disease, you have wheat allergy, and you have non-celiac gluten sensitivity. Celiac disease is very clear. Genetic trait, villi are destroyed. There are blood tests that completely, closes the loop on the diagnosis. Wheat allergy, very much like any other allergy you might have, it's IgE. There is no destruction of the villi, no genetic trait specifically. And the last one is non-celiac gluten sensitivity, which there's no genetic trait, no necessarily diagnostic blood test, and definitely no destruction of the villi. May or may not have some inflammation, may or may not have some genetic trait. So it's almost like, a chance. You can say you have this genetic trait, therefore you have a problem with gluten. It's all self-reported. So we have these three broad categories. And the non-celiac gluten sensitivity, very difficult to diagnose because of the fact that there's no blood test, no genetic test, no destruction seen in the gut. However, people classically get symptoms when they're exposed to gluten, not only from the abdomen, but other things like skin issues, mood issues, and autoimmune conditions. But again, are they actually reacting to the gluten, or are they reacting to the carbohydrates called FODMAPs, or fermentable oligosaccharides, disaccharides, monosaccharides, and polyols? What are these? These are short sugars found in these carbohydrates. So when somebody comes to us with this and we decide, we take off gluten and we tell them, are you feeling better? They say, yes, they are feeling better. And then when you reintroduce gluten, they feel like crap. Then you decide, oh yeah, you have non-celiac gluten sensitivity. So should they be on a gluten-free diet for the rest of their lives? What does the science tell you? That's what we're going to delve into. So non-celiac gluten sensitivity really occurs just like any other food sensitivity. There is some underlying gut damage. It happens over a period of time. So it happens it's not you're born, you don't have children born with non-celiac gluten sensitivity. Most adults in their third, fourth, and fifth decade have this problem. So focus should always be about rebuilding gut health. This I find very difficult because we ask our patients, we guide them through 90 days. After that, they're given the tools how to learn to eat for their health. But a lot of people fall on and off track. For example, they will eat a perfectly gluten-free diet, but will drink beer on the weekends. And beer is rich with gluten, right? Barley or whatever wheat, whatever you use to make the beer. So you're not necessarily gluten-free. So we don't know if we actually get a gluten-free period with a lot of our patients. So what I find is if they can focus and take it out and rebuild gut, and can they actually go back to gluten? If so, why should they go back to gluten? Now, remember the slide I asked you to park right in the beginning of this conversation, or maybe monologue, I should say. The digestion of that bread going down your stomach, which not only involves proteolytic enzymes. Look at this one, food intake, GLP-1, the incretin that helps with your glucose digestion, and the GLP is destroyed by DPP-4. Now, here's the unique thing about DPP-4. DPP-4 also helps with the digestion of gluten. That is key. Why is that key? So let's look at what happens. This is an interesting info. So I come from India, and one of the things I remember through medical school, I come from the south of India, where the staple is rice. North of India, because of how the field, cultivation of the soil, A lot of the farmers in the South grow rice, paddy fields. A lot of the northern have wheat fields. So wheat is predominantly northern India staple carbohydrate, and southern India staple carbohydrate is rice. When somebody gets diagnosed with diabetes, particularly in the South, they would immediately switch over from rice to whole wheat. They'll start eating something called chapatis, which is a flat bread made from whole wheat, particularly. Because what happens is when you eat gluten rich food and you are a diabetic, follow me on this one. When you are a diabetic, you're eating whole grain wheat, a gluten rich food. The DPP4 that destroys GLP-1, and remember, GLP-1 helps with blood sugar control because it allows your insulin life to be a little longer, pushing all of the glucose from the blood into the cells. So the DPP4 is occupied not by digesting GLP-1, but by digesting the wheat, right? DPP4, again, I typed it wrong right there. If you're looking at the slide, DPP4 actually is occupied by digesting the gluten. Go back to the previous slide, right? If you go back to the previous slide, it is digesting the gluten. Therefore, the DPP4, when you give gluten-rich food to a diabetic, it is digesting the gluten, therefore allows the GLP-1 to stay longer and therefore helping with better blood sugar control. You see how this DPP4 is affected by gluten? DPP4 is occupied eating gluten, therefore it is not destroying GLP-1, therefore your blood sugar control is better. That I thought was very interesting info. Now, second, when people eat a gluten-free diet, their triglycerides actually go up. That is another interesting thing. So when you're completely gluten-free, is it because most of the gluten-free products are replaced with sugar and maybe some fat because you're removing gluten, so you want to bring some taste and consistency to the food? I don't know, but there was an increase in triglycerides noted in people who ate completely gluten-free diet. Now, I don't know a little deeper into the study whether they ate processed gluten-free food, but there are natural gluten-free grains which you should be eating if you're going to go gluten-free, and you should not be buying any of the processed gluten-free foods. If there's any advice I can give you, if you have non-celiac gluten sensitivity that has been established by you going off of gluten for 6 weeks and it has been identified with some degree of stool testing, you have some guidance, it'll be important to understand not to eat any processed gluten-free products. You can go and get a gluten-free bagel or gluten-free flatbread or gluten-free. In fact, I think I was shopping at the Indian grocers and I found gluten-free whole grain wheat. That means they've actually processed that wheat. That's not even a whole wheat. How good is that for your health? I really don't know. What they also found is higher triglycerides, higher blood sugars. So what is the solution to this problem? Non-celiac gluten sensitivity has to be established. There is a way to diagnose this. There are more tests that are available now to establish whether you have non-celiac gluten sensitivity besides that Salerno's criteria where you remove it for 6 weeks and reintroduce it and see the symptoms. But the bottom line is you got to focus on rebuilding your gut health, whether it be lining, mucus lining, whether it be the how the enterocytes, the cells of your gut are the tight junction. That means how they hold on to each other. Is that gap correct, or is there a lot of inflammation there? All of those things we have to establish. And usually, if you have non-celiac gluten sensitivity, we work on replacing or helping you with your gut. Your timeline to recovery is anywhere from 2 to 3 years if you are following a strict gluten-free diet. I will say that again. The timeline to resolve non-celiac gluten sensitivity is 2 to 3 years. Now, even if you go back to gluten occasionally, You should not be doing it every day, because now you know that can cause inflammation of the gut. So should you be gluten-free for life? The answer is, I really don't know. You have to look at all of your health. Do you have a very severe autoimmune conditions? Do you have psoriasis? Do you have rheumatoid arthritis? Do you have Hashimoto's? If so, I don't think it's a good idea to go back to gluten. And again, don't go to gluten-free foods. Go to grains that are not that rich in gluten. So autoimmunity, skin conditions, mood disorders. You have a problem with depression. There's mild autism, attention deficit, brain fog. Probably going back to gluten is not a good idea. And then, of course, when the gut test results come back as poor, like lots of overgrowth and lots of inflammation, or joint conditions, like, swelling, pain, all of those things, gluten may actually play a role because you're not digesting the gluten well. Maybe your pancreas is not working well. Maybe you used to be a heavy drinker in your younger years and don't have enough of the proteolytic enzymes. Maybe you have inflammation of the gut. Maybe there are holes in the mucus lining of the what we call the enterocytes, or the cells of the small intestine. There could be so many things that could be contributing to your inability to digest gluten. So always seek guidance. I say this, I know there's so much of information on the web and online, but I find most people do, by the time they come to me, they've already tried experimenting. And, one of my coaches used to say, you trying to do something on your own because you feel like you've read the information and you think it's easy to do, is like saying, my friend is in town. I don't have his or her number, but I'm going to dial these 9 numbers in different combinations, knowing the area code, and I'm going to figure out how to contact this person. You'll be dialing forever, and by the time you reach your friend, you probably will not remember what you wanted to talk about, right? So that's what people lose a lot of time. They make a lot of mistakes by the time they come to somebody to actually help them with their gut health. So testing is very important. It's easy to establish whether you have non-celiac gluten sensitivity. Though I told you there's no testing, if you have HLA-DQ and you have the anti-gliadin antibody, most likely you are at a higher risk for non-celiac gluten sensitivity. You have autoimmune conditions. Your gut shows a lot of inflammation. It shows poor digestion, and it shows overcrowding or dysbiosis, imbalance of the good and bad bacteria. The chances are you are not digesting many of your proteins. There's a wheat Zoomer test. It's kind of expensive, but it's worth it if you want to get a good established baseline. And then I've told you about the celiac and the genetics that are associated with it, and blood work for antibodies. So much we could do. In fact, I find IgA saliva for gluten is also present. It's also a test that we can do through one of our labs. So get the right kind of guidance. I always say this, it doesn't have to be everything done together, but usually getting your gut testing, getting all of these enzymes together, it gives you a good insight into what is going on with your gut, and then having that guidance on what should you be doing with the gluten. Should you be off of gluten? Could you have little gluten, or should you be going off of it for a short period of time? All of that can be established. And then, of course, we do the IgE for wheat sensitivity also. Always work with someone who knows what to do. And I think this is where somebody who tells you blindly go off all these foods and then eat only these foods can not be made, may not be a sustainable diet. So again, it has to be made sustainable. You may need to look at your overall health before you make a determination of how long and what should you be off of. Here's the bottom line. Celiac disease is about 1% of the population. Wheat allergy is 9% of the population. From all of the studies, we think about non-celiac gluten sensitivity could be approximately 30% of the population. Remember, these are self-reported, but on paper, it seems to be around 13% of the population. And there are more and more people showing non-celiac gluten sensitivity and increasing intolerance to not only gluten but also other foods. And the reason for that is due to the gut and the immune system, not due to the food. So when you stop, like for instance, when I had my very first food sensitivity testing, I was sensitive to salmon, avocado, green tea, and olives and almonds, my staple at that time. I don't eat as much, I don't eat animal proteins, but do mostly plants. And I find that if you eat a certain food over and over and over again, the chances are you will develop some sensitivity. So rotating your foods is important, but also looking at the health of your gut. Fix the gut, you fix your health. I'll say that again. Fix your gut, you will fix your health. So if you have a food sensitivity, there's a problem with your gut if you don't have a genetic trait for celiac disease. So is there a judgment to this? Here's the judgment. When you have non-celiac gluten sensitivity, you're going to have all of the signs of irritable bowel, right? The bloating sensation, diarrhea occasionally, sometimes constipation. You don't know what it is. When it comes to celiac, it's a complete no-no. You're not absorbing any of your nutrients. There's active destruction of your small intestines. You can actually cause the fight is in your small intestine. So there's destruction of the villi, there's bloody diarrhea. So that's an absolute no-no. And removing gluten from the diet actually helps these folks. And then you have what is called the people who just don't have a problem. They don't have a wheat allergy, they don't have a gluten sensitivity. Those folks don't have to stay off of gluten. They will tell me, whether they remove gluten or they eat gluten, they don't see a difference. And usually they will not have any health issues, no autoimmune conditions. If you have autoimmunity, you should be gluten-free till we fix whatever is going on with your immune system. Your immune system should not be fighting against your normal cells. If it is doing so, something needs to shift. There is an imbalance there. Is it coming from a toxin? Is it coming from the food? The food usually is gluten or casein, which is milk, or is it coming from stress? Is it coming from the wrong kind of gut bacteria? Why is your immune system altered? Why is it attacking you? Those are the questions we get to ask. So hopefully this has been useful. And once again, as I said, non-celiac gluten sensitivity is actually a condition that is diagnosed by elimination of the gluten, and then reintroduction, watching out for symptoms. And it may actually exist, but what do you do with that? That has to be determined by an expert guidance based on your test results, based on your symptoms, based on your transformation of your health. Hopefully this was useful to you. And as always, shoot all your questions to me. And the bottom line is, don't follow anything blindly. Always question the science behind it. And once you get to the science behind it, you have the tools, the empowered knowledge to address this issue. And of course, you need some expert guidance always. Otherwise, you're probably going to be on a low FODMAP for the rest of your life, which is not good for you, or a gluten-free diet for the rest of your life, which may also not be good for you, particularly if you eat gluten-free processed food. Once again, I'm Dr. Chellam, founder of Holistic and Integrative Center of Novi and the host of this podcast, Women Wired for Wellness, and I will see you in the next podcast. Thank you very much, and looking forward to connecting with you soon.